Good morning, everyone, and welcome on behalf of the European Trade Union Institute in this seminar on cancer risks in healthcare workers, identification of hazardous medicinal products. And we are going to present in this seminar the ETUI's list of hazardous medicinal products. We have an hour, so without further ado, I give the floor to the first speaker, Ignacio Doreste from ETUC, who will say a few welcoming words from the side of ETUC. Ignacio, you have the floor.
Thank you very much, Marian, and good morning to everyone. ETUC welcomed the revision of the Carcinogens and Mutagens Directive. The legislation provides workers with greater preventive measures against exposure to reprotoxic substances and hazardous medical products in the workplace. This is so because the text requested the Commission to develop a definition of what hazardous medical products are, establish a list of these products. We will discuss about that later on, and also to prepare guidelines for the handling of these substances. ETUC welcomes the consultation and involvement of the relevant stakeholders, and of course, including the trade unions. ETUC acknowledge the very good work which has been done by EPSU and ETUI in the development of the guidance. The guidance are very soon to be published. The Commission has first concentrated in the preparation of the guidelines, whereas the list of the substances which will be considered as hazardous medical products will only be available according to the plan of the Commission in 2025. ETUC therefore appreciates the work which is done by the European Trade Union Institute in the identification of these 121 hazardous medical products, because this list is going to help to close this 3-year gap between the publication of the guidelines and the presentation of the list by the European Commission. It is very important for the trade union movement to be well aware of this list of hazardous medical products so as to protect workers by applying the guidelines, and also prioritization is key to create effective strategies when bargaining collectively with the employers. So thank you very much again, and I wish you a very good webinar. Thank you.
Thank you, Nacho. Thank you very much for these welcoming and warm words from the side of ETUC. So now we will have the next speaker, Ian Lindsay, and from the European Biosafety Network, and also the co-author of the list of hazardous medicinal products that we present today. And Ian will give you an introduction to this list. I'm sure he will also give some very interesting backgrounds. After that, we have time for questions, and you can write your questions in the chat, and we will try to take as many as possible. So please take this opportunity for an exchange. Ian, you have the floor.
Thank you very much, Marianne. So, in terms of the background to these particular hazardous medicinal products, they are used for a variety of treatments. The principal one in the past has always been cancer, and it remains obviously the principal one. And the type of products that are used in or understood in that category are cytotoxic, cytostatic, or antineoplastic. But one of the things that has happened over recent years is that the definition of hazardous drugs is much broader than the traditional exclusively cytotoxic approach, which is to look at a broader group of hazardous medicinal products, including antivirals, vaccines, immunosuppressants. And those products are obviously broader in terms of the definition and scope, but they also treat a much broader range of issues. So while cancer is the principal use of these products, there are a variety of other things, including multiple sclerosis, organ transplantation, lupus, psoriasis, Crohn's disease, and a whole range of other things. So I think one of the key things in terms of the future guidelines from the European Commission is that the scope is much broader anyway for the term HMPs. So what are the risks for healthcare workers and professionals from exposure to these hazardous medicinal products? And usually the exposure is over a long period of time, relatively low doses. It obviously, from time to time, there can be spills of these drugs, but the identified risks include the following: hair loss, which is a regularly reported phenomenon, things like taste disturbance and headaches, infections and respiratory diseases. But the more serious ones are obviously in relation to healthcare workers getting cancer, which can be breast cancer. Leukemia is a particular type of cancer that is often the result of these exposure to these drugs, but also importantly reproductive disorders, which are obviously in the main principally for female workers, but also affect male workers as well. So I just wanted to not go through all of this, but just to give you an example of a particular drug, which is very, very commonly used, cyclophosphamide, and it's if you like, a symbol of the issue. The International Agency for Research into Carcinogens has categorized this as category 1, which is obviously, a serious impact to humans, but also under the classification, labeling and packaging regulation, it's 1A reprotoxic and 1B carcinogenic and mutagenic. The drug has been available since 1959. It's an alkylating agent, which is again one of the most common and toxic of substances. It originates from nitrogen mustard, which I'm sure some of you will know goes back even to the First World War, when people noticed that the use of mustard gas had a preventive effect on cancer. The impact of the way it works is by damaging DNA in cancer cells, but obviously it also damages the good cells as well. And one of the ones it particularly affects, as I've just mentioned, leukemia is one of the things it can cause. It's rapidly absorbed, but like most of these, if not all of these HMPs, there are no agreed exposure limits or thresholds. Oops, sorry, yeah. Just jumped ahead. There have been reports of what the impact on exposure to cyclophosphamide in particular, using standard safety precautions, still resulted in urine samples that were positive for cyclophosphamide in those studies. But as we all know, these substances continue to be used for patient treatment and will continue to be, certainly for the foreseeable future, and therefore they can't really be substituted or replaced in any significant way. So this slide is from the work that the European Commission and RPA are doing on the guidelines, which again shows the breadth and scope of this activity and the concern, because again, traditionally, not only have people focused on cytotoxic drugs mainly, they've also focused mainly on the core risk areas in pharmacy and on the wards. What the work on the guidelines has successfully done is to ensure that the whole life cycle of the use of these products and the workers who are likely to be affected is included. So we start from the manufacturer, the formulation, the transport, the delivery and storage to healthcare facilities. We then go on to preparation and then administration. And then in terms of the disposal process, even into sewage. But obviously the effect on the workers who either transport or clean the wards or work in and around the pharmacy and so on, they're all potentially affected. And I think this approach certainly is the one that we would favour. And in terms of the numbers, we're talking about a serious, number of people potentially affected, 12.7 million. So, what does the EU legislation currently say about HMPs? Well, over the last few years, there have been substantive changes which have been as a result of healthcare workers and professionals, and particularly the trade unions, campaigning on this issue. So the principal directive, which was the Carcinogens, the Mutagens Directive, was amended on and finally agreed in March 22. One of the principal things that it included was mandatory training for workers who are exposed to CMRs, carcinogens, mutagens, and reprotoxins that are contained in HMPs. Significantly, it acknowledged that HMPs are CMRs and are in the scope of the directive. Previously, there'd been some doubt about that. So the reassertion, both in terms of the text of the directive and a joint statement that was made by the European Council and Parliament, has confirmed that not only was this directive extended, excuse me, to include reprotoxins, it was extended to include HMPs for sure. And then specifically, the European Commission was required that no later than the end of December this year, they should prepare guidelines for the safe management of HMPs, which is work that is ongoing. Oh, sorry. And then lastly, to develop a definition for HMPs and establish an indicative list of HMPs that Nacho referred to earlier, which is no later than 5th of April 2025. So that's one of the reasons we're talking about this list today. So what were the objectives that we set ourselves in terms of doing this list? Firstly was to identify which HMPs fall under the scope of the new legislation, to help users of the guidelines that will be issued hopefully by the end of this year, which specific HMPs the guidelines apply to, well ahead of the deadline in 2025, because without that, it's very difficult for the guidelines to be clearly applied by people actually working in healthcare. And lastly, obviously, to help raise awareness of the risks to healthcare workers from HMPs. In terms of the working definition that is being used by the group who is managing the process for the guidelines, which includes the ETUI, hazardous medicinal products are those that contain one or more substances that meet the criteria for classification as carcinogenic, mutagenic, or reprotoxic, either category 1A or 1B, in accordance with the regulation, which is the classification, labeling, and packaging regulation. So this working definition is actually a reflection of the definition that is included now in the new CMRD, the Carcinogens, Mutagens, Reprotoxic Substances Directive. So those two things are aligned. So effectively, this sets the framework for our list. What does it mean in practice with CMRs? CMRs are, as defined in the CLP, category 1A are those substances that are known to have CMR potential. Category 1B are presumed to have CMR potential, and category 2 are suspected to. We've used in the list the inventory lists that the European Chemical Agency publishes to basically come up with our application of the categorization system or the classification system, which focuses on category 1A or 1B CMRs. So how do we start, or what was the process? We started from what we believe is still the gold standard in terms of lists of hazardous drugs, or HMPs. We used not the 2016 NIOSH list, but the proposed 2020 list, which has been actually around obviously for about 2 years now. It's still in theory a draft, but is effectively the next step of the process. And then we looked at the process to see whether any of those substances, the 229 substances that are on the NIOSH list, were category 1A or 1B, or category 2, which is the third category, but not included in the directive. If they weren't, we discarded them. If they were, we carried on. We then looked at whether they were approved for use in the EU by looking at a number of the national lists that are published, again, on the European Chemical Agency's website, showing that they are current substances, and these lists are usually updated every week or two, so they're pretty good in terms of showing what is currently available in the EU. If they were, they went forward, and we separated them at this stage into what we call Annex 1 or Annex 2. So Annex 1 lists 121 substances that are category 1A or 1B, according to the classification system of the CLP. And then there were a further 47 that were in Annex 2, which essentially is the category 2 substances, which are not strictly within the scope of the EU legislation. And so that just gives the numbers that I've just been talking about. Oops, again, sorry, I keep jumping ahead. This is what the list at the back of the report says. And as you can see, there's quite a lot of detailed information, which I'm not going to go into now, but you can see that if you take the top, we've categorized it by whether they're CLP 1A, 1B, or 2 for the 3 areas. We've included the CAS number, which is the principal way we've identified them. Then we've looked at the list number in the European community, what therapeutic groups they identify of, principally the principal therapeutic group, and then whether or not they're in the IARC list as well, similarly with NTP, and then manufacturer's special handling information, which is a particularly American orientated NIOSH thing. And lastly, where they fit in the NIOSH table. And then the last category is basically looking at those substances where ordinarily the self-classification, we've identified those that are clearly 1A, 1B, or 2, but where there is some doubt about that or a disagreement about that, they're not convincing evidence, we've noted that down in the list. And similarly, we've done the same thing for the category 2 substances in Annex 2. And we believe that the same approach, the same precautionary approach should be adopted to these substances, even though they are not within strictly the scope of the EU legislation. We've also set out in the report some of the weaknesses that are potentially there. As I've said, the HMPs are identified principally by the CAS number. We would like to have been able to give a full list of the names of the drugs, their brand names and other names, but frankly, there are too many names, different languages, different approaches, and therefore we've identified usually by their principal name and their CAS number. And as I say, we would like to have gone broader, but frankly, it wasn't possible to do that. As we've said, our starting point was we used the NIOSH 2020 list, which could mean that some substances that are currently available in the EU but not in the US may have been excluded, but we think that's probably unlikely. Again, it is possible that for a number of reasons we may have made a mistake in terms of those that are unavailable we believe are unavailable in the EU that could be available, but again, we think that's even more unlikely. And lastly, I think it's very clear that this list of HMPs is only representative of the situation, probably on the day that we finalise the report, and will need to be updated on a regular basis. And I think it's fair to say that our commitment will be that we will try and do that as much as we can. So how does the list compare with other existing lists of HMPs? The draft EU guidelines lists a number of those lists, but they are, again, sometimes pretty difficult to access. And as it says itself, they're sometimes difficult to use. But I just wanted to remind you again about the categorization, this idea that HMPs are substances which meet the classification 1A, 1B under the CLP. Because in Annex 1, we have only listed those that are covered by that. And therefore, we think that is pretty much the definitive list. No other list, as far as we understand it, currently published, has applied that approach, looking at the definition that's used in the CMRD and in the working group. And therefore, the lists that are currently available and potentially to be consulted use their own criteria and rely on a range of different definitions. If you look at them, there's very little consistency in their approach. But we looked at comparing our list with many of those lists, and we believe there's a pretty good match. And as I say, most of the existing lists don't use the 1A, 1B under the CMR. We looked at a number of these lists, and basically our list is pretty much covered in these published lists. So in terms of conclusions, as I say, this is the first and the only list of HMPs that's publicly available, and it's freely available on the ETUI website, which identifies the hazardous drugs that are used in the EU and fall strictly within the scope of the CMRD. We believe that Annex 2, category 2 substances, still pose a threat to healthcare professionals and workers and should be treated in the same way as Annex 1 in terms of the application of the guidelines and so on. In terms of the impact, we believe that the guidelines will have an impact, and they will have a greater impact if our list is used effectively, and it will help to prevent occupational exposure for a number of those areas and potentially affecting millions of workers in the EU. And obviously the kind of problems we've talked about, cancer is obviously the most, high profile one, but miscarriages are clearly a very high recordable occupational exposure risk. And we're talking about, as I said before, not just manufacture and use, but a much broader definition in terms of the life cycle. And one thing I probably should mention at this stage as well, also it applies to veterinary practice as well as just healthcare. So we believe that the ETUI list can also be used by the Commission to help its legal obligations to establish by 2025 an indicative list of HMPs that are CMRs. So that's it. And as I mentioned, thank you for your attention. The list is available here for anyone who wants to take it. So that's it. Back to you, Marianne.
Thank you. Thank you very much, Ian, for this comprehensive introduction into the list and its background and its possible uses. I think it was quite enlightening. I can say that we have 91 participants to this seminar, which is also a very good sign of interest into this list, I think. We are now going to some questions, and those questions will be answered either by Ian or by my colleague Tony Musu, who is the other author of this ETUI publication. And we have 3 interesting questions. So I'm not going to make a selection. I'm going to give them to you, all of those 3 questions, and then we'll see whether there will be other questions provoked by this. So there is a question from Jürgen Moog, Jürgen says a guidance on HMP will be published by the Commission end of this year, but this only concerns the CMR effects. So the question is, why will the Commission not also make a guidance on HMP which have other very serious effects? So it's basically maybe a question to the Commission, but maybe you can reflect on the question. So open up to other serious effects. Then there is a question of Andreas Flückiger, and this question relates to the issue of hazard and exposure. So and then risk. So risk to healthcare workers is a result of the functions hazard and exposure. The list covers the hazard proportion, which is the easy part, as it can be based on the effects of full therapeutic doses, and non-clinical data, also usually high dose. What about describing the exposure part? What tasks lead to exposures and how high are these exposures? There are well-documented OALs available for all commercialized drugs that such exposure data could be compared to. The question is there any intention to actually discuss risk instead of focusing on hazard? And then the third question is, are there any longitudinal studies on the incidence of cancer among exposed workers? And this is a question of Dr. Lauwe. And then we might want to give the floor to DG Employment, to the Commission. There is also a request from Ralph Kleinschmidt from DG Employment. So let's first do the answering of the questions, and maybe Ian or Tony, if you think it's a good moment to give the floor to Ralph Kleinschmidt, then please say so, and we'll try to do that. You have the floor, either Ian or Tony.
Maybe I can take some of the questions. I don't know. Well, good morning first to everyone. So I'm Tony Musu, the co-author of the ETUI's list on HMPs together with Ian. We will check with Maria, our colleague from ETUI, whether we can give the floor to the participants to the webinar, whether it is technically feasible. But I will maybe take the first question from Jürgen. So the guidelines that are being prepared by the Commission, they indeed take into account all ways that these drugs are being used in the healthcare sector. So of course you haven't seen the guidance yet, because they will be published only beginning of next year. But the way the guidance are built is that they look at all I would say the supply chain from the manufacture of the hazardous drugs to how they are prepared in pharmacies, how they are injected in hospitals or at home for nurses working in home, in patients' home, and even the cleaners, but also the waste management of these drugs. So the guidelines, they look at all the possibilities on exposure to these drugs at work, and they give advice on how to protect the workers. The idea, of course, of our list is to help the users of the guidance to identify the hazardous drugs to which the guidance apply. So we believe that these two tools must be used in conjunction. So of course you need the safe advice on safe management, but you also need the list to which these guidance apply to. So to answer your question, the first question of Jürgen, so I would say that the guidance that the Commission will be published very soon apply to all drugs, because you know they whatever their adverse effects. But of course, the legislation is such that the Carcinogens, Mutagens, and Reprotoxic Directive only apply to those drugs that are carcinogenic, mutagenic, or reprotoxic. And that's why our list is only focusing on, I would say, the scope of the EU legislation. Ralph, I see you on the screen, so maybe you want to complement the answer. You have the floor then.
Yes. Can you hear me loud and clearly? Very good. So my name is Ralph Kleinschmidt, and I'm representing DG Employment Unit C2, and I'm more or less the head of the project EU HMP guidance. So first of all, thank you for that work to Tony and Ian. I think this is very useful for us, and as you already said, it can complement our work. And as I have retained from your presentation, Ian, we have already your permission to use that list and to link it in our guides, which is good, because in our guidance, we already have a chapter on how to collect the information. There are various sources in it, and I think your list indeed is really a good complement for that work in our guide. Maybe I would like also to comment a little bit on the question of the definition and the list. First of all, the definition. As Ian already said, it is a certain definition which is linked to the legislation. So the underlying directive, the CMR directive. And that would inspire us to develop this definition. And this definition, and that's something we have maybe to underline at that point, is a working definition. nothing more for the moment, because as you have explained in detail, a second part of, if you wish, that project is to establish a definition and an indicative list. That will be done later on for us. So if I stay just with the definition, it's a definition which is a little bit, it's not a broad definition if you compare with other lists, but it is linked to our legislation. And that's quite normal that we need to have a consistent approach from our legislation into our guide, because it's more or less implementing what the legislation says. But we have to keep in mind that it is nothing more than a working definition for the moment. And as we are following a tripartite approach, this definition was approved by the steering committee. Tony, as a representative of the association and the works in general, was also part of it. And we decided at the beginning of the project to retain it as a working definition, because we have to define what we are speaking about. But as I said, I think there is something which is going on later on. And as you have already said, it's a quite complex project. So when we are developing that next step, the list, we need to take into account, as it's already said, the latest developments in scientific knowledge. We will have to develop a methodology why these substances will be included in that list. And we have to consult the national experts in the European Union, because as you probably know, in different countries, we have already these lists. There are even more developed systems which exist, and we have to take these people on board. And we have also to consult our key stakeholders, because we are following a tripartite approach. We are consulting not only workers, but also employers and also national governments. All this is to say that we need a certain time for doing the next step. And so the first step in that right direction, the ETUI list, is very, very much welcome. When we launched that project of the guidance, we're in the situation that we had a lot of work to do. As you said, it's a guide which is covering the whole life cycle chain, starting from manufacturing until the very end, when we are going into waste or wastewater. And that's why it's make it really a challenge to do that in just 9 months. So at the beginning, we decided to have only a working definition, and we decided not to establish a list, but we included a part on it, several pages, where we're providing a lot of information, how these information can be collected in the various lists. And amongst others, also the NIOSH list, which is a good source. The 2020 version is not yet approved, but it is now, let's say, maybe a good information tool amongst others. And as I said, I mean, our next project will be to have something on a European level and approved by all the different working parties and interest groups on the European level. And that might take that time. That's why we have that project scheduled for 2025. And when we discussed that at the beginning, I know that very much, if we should focus on a list or not, we decided that we have a guideline which is focusing on the other part of the work, which is to protect workers. And as Tony has very good explained, yes, we have a definition which is limited to CMR substances, but the guide isn't, because we are taking probably the highest risk, and then we are foreseeing protection measures on that level, which can also include other hazards which are coming from the drugs, even if the definition is limited to CMR. So in my head, I still have a distinction between the definition and the guide. The guide is for the people working on the floor, in a hospital, in a manufacturing site, and they should use it to protect themselves from whatever risk we can imagine. And that's how we tried to attack the guide and try to develop the document. And since we had really limited resources, again, we are focusing on the whole life cycle chain in 9 months, and we are organizing a broad key stakeholder consultation, because we organized more than 10 workshops for every part of the life cycle chain. We prepared the first draft, which is now up to consultation by the key stakeholders. And we are going now in next phase, where we try to consult people in the form of pilots. Pilots, what does that mean? We are taking our document and we're presenting it to people in the hospital, workers, employees, and asking them their opinion. What do you think of the document? So we're going from the level of the European associations down to the level of the the workers on the ground floor and ask them, what do you think of our guide? Is that something which is really usable? Can it be used? And we try to describe as much as possible what should be done to protect workers. And that's, I think, for me, the focus of that guidelines. And I think your list, as well as the list which will be established on the European level in the next years, is something which can complement that work. But for the moment, given the limited resources, we were focusing on that part. And in that context, thanks a lot to Tony and all the other people which have worked with us to develop the guidelines. It is a huge work. We are still under heavy time pressure, but so far what we received as a feedback from the stakeholders, it was only good. So thank you very much for your support during that work. I hope I have answered on all the questions, also the definition which came up first. The question with the hazard, which I've also seen, is also a good question, because obviously between the hazard, which is in the nature of the substance, and the risk, which is related how you are exposed afterwards, there is obviously a difference. But I think our guidelines cover this point. We are looking actually at the risk, because we are recommending to make some exposure measurements. What I've seen in the comment as well was that the person said that there are OEBs available all over for the pharmaceutical drugs. That's something interesting, maybe not according to our experience that we have OEB all over, at least not recognized OEBs. We have some of them which are given by the manufacturers. And that is interesting as well to hear an opinion, Tony and I, on the problem of the OEBs. And the other part I heard as well during our workshops and afterwards when discussing with the expert, that the exposure to the dust is maybe not the main exposure way we are facing for, first of all, a hospital, maybe in a large scale on a production side, but the experts in the hospitals told us it's mainly the dermal exposure, which is the main one when the drug goes through the skin. Happy to discuss it. Thank you.
Oh, okay.
Yes, thank you very much, Ralph, for this intervention that indeed answers many of the questions in the Q&A. But maybe I would like to comment on the definition. So indeed, at the start of the work on the guidance, we had to agree on a definition for hazardous medicinal products. Otherwise, you don't know on which substances the guidance will apply to. And of course, the definition that we agreed on is a working definition, and it is totally in line with the scope of the Carcinogens, Mutagens, and the Reprotoxic Substances Directive. And let's be frank, the working definition that we have adopted, we know already that it will be the final one in the legislation, because it cannot be otherwise. So the working definition is already the final definition. This is important to mention. No, Jan, I don't know whether you want to intervene to complement what Ralph was saying.
Yeah, I mean, I think if we are being practical and frank, as you just said, if you look at guidance that exists, that Ralph and his team are looking at as, if you like, the benchmark or the basis, much of it is narrow in its scope. It only looks at antinoplastics, or only looks at cytotoxics, or only looks at the high-risk areas. So what the scope of work of the guidelines and the legislation that Tony rightly says underpins it is dramatically different, and that the workload, as Ralph said, is significant. But what it means is that healthcare workers and professionals throughout Europe will have to apply a different way of working and a different set of words in their national guidance documents as a result of the legislative changes, the definition of working or otherwise. So that fact means that there will need to be a significant amount of effort in the dissemination and application and implementation of the guidance. Because if you are a member state and you have, as I say, partial or narrow or specific guidance that only relates to a part of what the EU expects member states to cover, that's a lot of work beyond the work that Ralph is currently doing. So I think I don't think we should underestimate that. I'm not sure saying we are, but I think we need to adopt a very different sort of mindset in looking at how workers will approach this issue. And the guidance that will be issued by the Commission, I'm sure, will be an improvement. But without a list, it's very, very difficult for workers on the ground to do that. At the moment, they usually have a look to the NIOSH list. They usually adapt there to their own circumstances in their own workplace or in their own country. But the reality is, as Tony says, the definition is set by the legislation and will be used, and therefore we kind of need to move on from that. We know there's going to be a list published in 2025, and I'm sure it will be an improvement upon ours, and as Ralph says, it needs to involve the stakeholders. But I suspect it's not going to be substantially different. So therefore, we think what we've done will help complement the rollout of the guidance in the short term, and hopefully will be used in the process that Ralph referred to. But it's 3 years away, so we need to do something. Otherwise, my fear is that the guidance will be published and it will have a lesser impact without some reference. And the lists that are published at the moment are very different, with very different definitions being used, very different classification systems, and they may be appropriate for individual circumstances, but in terms of the ambition of the EU, I don't think they cover it. So, Ralph.
I don't know how to raise a hand by that system, so I do it just by video seems to work. Thank you very much. Yes, first remark, I don't know, concerning the definition. That's your remark, Tony. I don't know if we will end up in the same or not. It's part of the project. And the same for the list, I don't know, because we are currently investigating, and I have described a little bit how we are working with a tripartite approach. We are trying to use the latest scientific knowledge which is available. All that will go into the project, and at least me, I don't know the end of the project. That's class bowl, which can foresee what happens. I don't know. But Ian, I think you have made a very good point. The guidelines are of utmost importance if you want to protect workers, but they can only be important, they can only have an effect if they are used. And that was more or less, that was the basic idea of that project, that we tried to incorporate all stakeholders on all levels, associations as well as workers, and tried to create a document with really kind of handsome and with a practical use. But I think there is a phase after we have published this document, which is very, very important, and we need your help. We need the help, by the way, of every association working in that field. Because between us discussing in a webinar, between us discussing in a steering committee, and between us having talks with all the experts and bringing out disseminated documents, there's a huge gap, which is called communication and awareness raising. And we had already a talk that morning to another expert, also from the workers' side, and we agreed that we need a kind of awareness raising. And that's also something I'm looking for, a strong cooperation with you. We need now, once we have finished the work and we have still 2 heavy months to work on. But afterwards, it will be, I think, a very good document. Then we need your help to disseminate the guidelines in the interest of the workers. And if everything goes well, it should be linked to kind of awareness raising, because I think it's not yet sending out to people, it's to explain what is written in the guidelines, what kind of roles we have on the guidelines. I mean, we have foreseen a role from top down to every part in the hierarchy, and they have to play a role in it if the guidance should be successful. That's the truth. And I think for that we need awareness raising on different levels, and that's where we need your support and your help. Because if the guidelines are just printed out, lying in the cupboard, it's completely useless, and we need it to have in the hand of the workers. And as you probably know, one part in the guidance will be so-called one-pagers. What is a one-pager? It's a simple instrument, a simple one-page instrument giving instructions to workers on the ground floor. That's an example we are giving. We will give several examples in the guidance, but that should be really how we can disseminate the document to put it in the hands of the workers to see what they should do in order to protect themselves. That's the idea. But again, in very good point, our work is not yet done. We will see how we can also support the dissemination of the guidelines, but there is a communication part afterwards, which is of utmost importance, because it's completely useless if it's just on the website or printed out. It has to be in the hands of the workers and the employers and all other key stakeholders in that field. Thank you.
Yes, thank you, Ralph. But of course, you can rely on us to disseminate the guidance that will be published beginning of next year. Indeed, that's very important if we want to try to lower the number of cancers and reproductive disorders that we see in healthcare workers because they are exposed to these hazardous drugs on a daily basis. But maybe I would like to answer some of the questions in the Q&A box. So we still have the question from Dr. Lawege. Is asking about the incidence that we know on workers. And you will find all the details in our report. There's a section on the background information, and there you can read that we have studies showing that hospital workers who handle these drugs are 3 times more likely to develop cancer. And specifically on nurses that are exposed to these drugs, they are twice as likely to miscarry. So these are, just to answer your question, Dr. Lawege, you have all the background information in the introduction of the report. Again, I would like maybe to take the opportunity that Ralph is together with us today, also to thank him for the good collaboration. And indeed, all this work is being done in a tripartite way. So it means that not only workers are involved in the discussion, but also employers and people from the member states, the governments. And of course, we all work in the same direction to try to improve the health and safety of workers in the healthcare sector. That's very clear, and we will continue to do so in the coming months, because the project is not over. The guidance that the Commission is preparing are still under construction, and again, they will be only published beginning of next year. So I see the time, and we are almost at the end of our webinar. So maybe I would like to draw some conclusions. And of course, the people that are with us today, they can still write to us if they want to continue the discussion. But what we can say today is that the issue on hazardous medicinal drugs and the adverse effects that they can cause in workers in the healthcare sector has long been neglected. And recently, we can say that the EU legislation has been revised, and that these hazardous drugs that are CMRs are now clearly in the scope of the Carcinogens and the Mutagens and Reprotoxic Directive. And for all workers exposed to these drugs on a daily basis, and we know that there are many, Jan was giving the numbers, there are almost 13 million in the EU. It is, of course, important for all those workers to identify these drugs in order to take preventative measures and avoid exposure. And 3 years ahead of the deadline that is imposed on the EU Commission to set up the list of HMPs that fall under the scope of the legislation, well, ETUI has done the job already. So, and in Annex 1 of our list, you will find 121 hazardous medicinal products that strictly fall within the scope of the directive. But we also have identified in Annex 2 other hazardous drugs, which are not strictly in the scope of the directive, but which should be treated as those in Annex 1 in a precautionary approach. And there we have many other substances that maybe one day will be recognized as carcinogen, mutagens reprotox 1A, 1B. As explained by all speakers, the application of the guidelines that are being prepared by the Commission to the drugs identified in our list will certainly help prevent future occupational cancers and reproductive disorders related to the use of these hazardous drugs. And finally, the ETUI list can be used by the EU Commission to help meet its legal obligation to establish by April 2025 an indicative list of HMPs that are CMRs. So we are now at the end of this webinar. I hope that it was useful for your work. I would like to thank all the speakers for their contribution, all the people online who participated to this webinar. I would like also to mention that the recording of the discussion will soon be available on the YouTube channel of the ETUI. So don't hesitate to watch again this webinar or share the link with all those who couldn't be with us today. So again, thank you and see you soon for other events organized by ETUI. Bye-bye.